Perfect. Okay, so let's begin today's session. As we begin, my name is Victor Ndusi. I'm a consulting research fellow for HEI based in Nairobi, Kenya. Welcome to today's session. We have the chat open. Just a couple of housekeeping announcements. So you can introduce yourself. Feel free to do so. I see folks are already typing into the chat, so feel free to introduce yourself, where you're from, where you're joining us from. We have the Q&A function as well. As we proceed through the session, I would encourage you to send in your questions for today's speaker through the Q&A function. And as always, we'll make all the recording and material for this session available on the HI website, and we'll share a link to that in the course of this session. So before we begin, just a few words about HEI and who we are. So we are a nonprofit. Our mission is to provide impartial science to inform decisions that foster a healthy environment. We do this through three programs. We have an energy program, an environment and health program, and a global initiatives program, where I belong, and which is the program that's bringing you today's session. So for the global initiatives program, we really focus on a couple of things: providing high quality impartial data. You would be familiar with the State of Global Air Initiative that brings you the annual State of Global Air report. This is one we did for Africa in end of 2022. Also, just looking at exposure and health impacts across the continent. Similarly, we do scientific capacity building and strengthening activities, which is the pillar that brings us here together for today. We also do a bit of evidence synthesis. The example I'm giving here is a recent scoping review of air pollution and health studies in East Africa, completed last year in April. We are in the process of beginning a new one for West Africa this year, hopefully publish it next year. So really looking at the breadth of evidence available on air pollution and health in different localities across the region. Lastly, but not the least, we also do engage in collaborative networks such as the Africa Clean Air Network, through which we have an annual forum, one that's happening this year in Pretoria in July. And we look forward to seeing most of you, if not all of you, at the forum. So this is just a brief of what we do in the Global Initiatives Program. We have activities in Africa, South Asia at the moment. So why are we here today? So we've organized a series of 5 topical areas for this session, for this particular training series. Last 2 weeks ago, we looked at air quality monitoring in great detail. Today, we're focusing on exposure assessment and how that looks like for health studies. We have 2 more sessions to come throughout this month, on the 16th and on the 30th. So as you've registered, we also encourage you to participate in those sessions as well. So for today, we have a similar agenda last time. So a brief welcome, which is what I'm going through right now. And we'll invite our speaker to go through today's topic, approaches for exposure assessment, 50 minutes or so. And then we'll have, through the Q&A functions and the questions that you send in, 25 to half an hour of questions and discussion. So today's speaker is Professor Benjamin Barrett from the Imperial College London. Ben focuses a lot on improving the resolution of exposure assessments for large-scale population studies. He's done work in the UK, in East Asia, and in Africa as well. He's also an advisor for the UK government and the World Health Organization, and we're happy to have you, Ben, with us. So I would like to hand over, without further ado, to Ben to take us through this session. Welcome, Ben, and I will now stop sharing my screen.
Thank you very much, Victor, and thank you to the Health Victor Institute. Hello, everyone. Thank you for joining. I'm just going to share my screen. There. So I'm going to, as Victor says, I'm going to give you an introduction or an overview about air pollution exposure assessment through measurement and modeling. And this really is intended as an overview to introduce you to some of the methodologies that are typically used, including fixed monitors, ecological models, personal monitors, and dynamic models. So that's running through the different approaches that are typically used across the world, but also touching on why this is important. It's not just for research, it's very much for policy, public engagement, etc. So we'll talk about why we do all this assessment. And then I'm going to finish off in some examples of how we can actually protect public health through exposure reduction and use these exposure assessment techniques to engage with the public. So first of all, some methodology. I've started off with something that many of you will be familiar with, and that's the use of fixed air quality monitors. These are either reference monitors, which is the top right-hand corner, the left-hand corner. These are fixed government-run reference monitors from across London showing a current air quality at that particular time when this screenshot was taken. So there's a pretty good distribution across London for these monitors, representing what air quality is like at that time. More recently, there's been a huge increase in the use of lower cost or mid-cost air quality sensors across the world. So the bottom map there shows this distribution of these networks, including sensors, which are typically much more frequent, much higher density, but you can immediately see that distribution is not equitable. There are parts of the world with many thousands of sensors distributed, and then other parts of the world with a complete absence of air quality monitors. But nevertheless, air quality monitors in fixed location are the sort of foundation of air quality assessment. But increasingly, models are also being used. Models have the advantage of being able to fill in gaps between the sensors. So where there is not any kind of measurement data, you can fill in that gap with some form of model. And there are lots of different types of model. The top right there is an urban atmospheric emissions inventory model, which is a bottom-up approach. It uses the emissions data that's available, in this case in London, to model air quality at a very high spatial resolution. This is down to 5 meters, and you can clearly see the roads, the main roads picked out in that heat map from there. But also, when you're on a much larger scale, or where there isn't the emissions inventory data available, increasingly satellites are being used to expand the coverage of the models to global scales. And there's some extracts from different parts of the world there for PM 2.5. And these aren't just satellite measurements, they're a combination of satellite with machine learning techniques, ground-based validation, and often land use models as well. So this isn't a satellite product in itself, it's an adapted satellite product, which allows you to take an atmospheric column from the satellite and apply it to a surface concentration. I'll speak a little more about that later. So these models can be very powerful in increasing spatial resolution of exposure assessments, but they can struggle sometimes to get the temporal resolution. An air quality sensor can go right down to 1 minute time resolution, whereas a model is either daily or annually, typically. So if we go back a few years, this is a schematic of how exposure assessment has been carried out for many years in different parts of the world. And this takes typically outdoor sources at one end, outdoor sources of pollution, applies them to a particular location, and that location is applied to a population, and that is their exposure assignment. And then it's linked to some form of health impact or health outcome. And this is the basis of much air pollution epidemiology, in fact, environmental epidemiology in general. You are linking a location to an exposure to a health impact. And this is really important for historical health associations and actually really quite powerful. This is a seminal study called the 6 Cities Study by Dockery et al. Back in the 1990s. And what's remarkable about this is it used a relatively crude method of exposure assessment to look at health associations between mortality rates and fine particulate matter, PM 2.5. That's the chart on the right. The one on the left is total particles. So each letter, P, T, W, L, H, and S, is a different city in the US. ranging from Portland, which is a relatively rural, relatively clean city, to Steubenville, which is the S, which is an industrial, or was an industrial city, which saw much higher levels of particulate matter pollution. And when you related the populations from these cities to the exposure of PM 2.5, you found this almost linear relationship, i.e., the risk of mortality, premature mortality increased as the pollution levels, PM 2.5, increased. Now, often in science, particularly in epidemiology, we simply don't get straight lines like this. This is too good to believe or too bad to believe if you're a resident of Steubenville. But it had a major impact for setting legislation. Consequently, this has been taken to court several times, reanalyzed at least twice, and the same relationship has come out each time. So this is a very, very robust finding, even though you're assigning the same exposure for all of the residents of each city across the US. So pretty basic, but very, very powerful. As our techniques have improved, we've refined this exposure assessment method somewhat. And now, rather than just assigning an entire population of a city or a town the same assessment, we can look at a much greater spatial scale. So we can add the home in, where someone typically spends most of their time living in a particular location. So basically the same. We're linking outdoor sources through to health impact, but at a higher spatial gradient. This is an example from South London, but there are many, many of these studies around the world now, looking at a particular census population area where we had detailed health records of the residents within that census area, and we could link that to this kind of high spatial resolution assessment model to see if those people who lived in more polluted parts of the city had a higher risk of developing cancer, developing cardiovascular disease, in this case, incident of stroke. So we found a relationship between stroke rates and the more polluted parts of the city in the northern parts of the borough. So this allows you to look in much greater detail at what someone is exposed to in order to have a more robust and refined view of what their health risk is. Models are coming on, and I mentioned that they were typically very spatially revolved but struggled temporally. In some cases now we're able to produce these higher temporal resolutions. So you input meteorological conditions to look at particularly diurnal variations in pollution levels. And this animation is nitrogen dioxide of London as it evolves throughout a day in January. So they are improving all the time. They're becoming higher resolved, they're becoming more accurate. And as that happens, we've got greater capacity to link some form of exposure to a health outcome, increasingly acute health outcomes as well as chronic health outcomes. Also in scale, the epidemiological methods, and you'll be hearing about this more in later lectures, have scaled up considerably. So as we've been able to assign more detailed exposure estimates to populations, so we've been able to expand the size of our studies. And really this is exemplified by a series of studies funded by the HEI, one in the US, one in Canada, one in Europe. These had very aligned exposure assessment methods using a combination of satellite, land use, and machine learning, as I mentioned before, to assign these three populations with exposure estimates and then link them to various health outcomes. And then to see if the different populations came out with similar dose response curves, whether the different pollution climates, the different geographies, the different ways of living actually led to different health outcomes and different understanding of how air pollution affects our health. And actually, there are a lot of alignment between these three studies. But if you look at the size of these cohorts, of these populations that are being studied, 60 million adults in the US, 8.5 million in Canada, and 28 in Europe, this really is scaling up to full national population in your cohort studies. So really, really powerful and many steps on from the 6 city studies that were produced in the 90s. More globally, things are still developing. So the US and Europe benefits not only from some very high quality models, but more importantly, it benefits from some very detailed health records. And if you want to look at health impacts, you need both to be able to find associations between the two. But thinking just in terms of exposure assessment, one important thing is not to consider simply where the most polluted places are, but actually where people live. So when you combine these two maps of population density and global estimates of PM2.5, looking for those areas that have a combination of both. So this is a few years old now, but certainly northern India and around the Himalayas stands out as high population density, high PM2.5, as does China and that East Asian area. Conversely, there are areas, particularly in the northern African continent around the Sahara, which are more sparsely populated but have very high levels of PM2.5. So overlaying, considering where people live and the exposure levels is important for health impact, assessing health impact. But that's just considering ambient air pollution levels. Still, much of the world relies on traditional fuels, biomass, charcoal, and other fuels for heating and cooking. Some cases both, some cases just cooking. And the use of these poor quality fuels, often in poorly ventilated indoor spaces, can lead to very high levels of exposure. And this is very differently distributed across the world, ranging from very low rates in some parts of the world to really dominant rates in other parts of the world, particularly, again, African continent. So you need to extend ambient air pollution levels with population density, with indoor air pollution levels to get a true picture of the levels of pollution that people are exposed to in their daily lives. And this really begins to expand your understanding of the health impacts. So this is a few years old now, and it's almost continuously updated. And again, I'm quoting the HEI, some really good work on the state of global air on this. But in doing that assessment as to your national health risk from these various outcomes or risks, it's important for a nation to understand what level of priority to place on these different risks. So if you pull out household air pollution here, about halfway down, and ambient air pollution here, these are seen as, on average across the globe, pretty high health risks. But that varies from country to country. Some parts of the world have a high ambient air pollution risk and a low household air pollution risk. Some parts of the world have low for both. Some have high, low for one, low for the other. So this state of the global burden of disease study is really important to understand nation by nation where priorities should be set in terms of health improvement and public health protection. So that's one area where this global level of exposure assessment can really help governments develop policy and prioritization for spending plans. So where are we now in terms of exposure assessment? I've talked about ambient. I've begun to bring in indoor, but when you look at how you or I interact and move about during the day, you realize that how much pollution we're exposed to is really quite complicated. We've got outdoor sources of pollution and indoor sources of pollution. No matter who we are and where we live and how we behave, there will always be some indoor and some outdoor pollution that we're exposed to. Those indoor sources, how much we're exposed to is a function of the building, whether we're inside the building, what that building design is, and how much ventilation is. So how quickly the indoor source of pollution can disperse outdoors. The outdoor sources, conversely, the infiltration rate is important. So very basically, if you've got a window or a door open to a building, then outdoor sources can come in through infiltration and indoor sources can move out through ventilation. And this is a balance between the two. We also travel between the two using different modes of transport, different routes. And the vehicles that we're in, whether it's a train or a bus or a car, all have different infiltration rates. And I'm going to show you some data on that in a moment. So this balance as we move between home, place of work or school, and travel between the two all changes how much pollution we're exposed to. how long we travel for, what time of day it is, it dictates our exposure. And then if you move into dose, that's what volume of pollution we breathe in. You need to consider the breathing rate. So some levels, some active transport, like walking, running, cycling, you're increasing your breathing rate. So you're not increasing your exposure, but you are increasing your dose. There are different pollutants, which all have different balances across this matrix, and they have a combined effect as well. And then you bring in other things like noise, green space, light, etc., all to add a lot of detail to this picture, but these things are very important. I'll explain why breaking it down to this level of detail is important in a moment. So there's some data from some past studies. The left-hand panel is a study carried out in Spain, in Barcelona, and that gave a cohort of, I think it was around 40 participants, portable monitors, and measured how much nitrogen dioxide they were exposed to when they were at home, at work, in other locations, and in transit between the two. And you can see on the left-hand panel, they spent most of their time at home, then work, then elsewhere, and a relatively small amount of time in transit between them. So this is pretty typical for a population. Most of us will spend most of our time at home. If you look at the right-hand pane there to the left, it's the concentration they were exposed to. So even though they spent relatively little time in transit, the exposure to NO2 they experienced in transit was highest. Now, if you translate those findings much more recently, 10 years later, to an African setting, these are 6 cities in different parts of the African continent. And you've got a similar data here. Each city had around 40 participants. And in the box plots, the green there is the proportion of PM 2.5 exposure, and in the purple box, the proportion of time spent. So you can see that in most countries, people spend around 60-70% of their time at home. And around, these are children, sorry, I should have pointed out, these are school children. So it was at school rather than at work. They spent around 15 to 25% of their time at home. So the proportion of exposure is very strongly dictated by the proportion of time spent in these different environments. So even though you may be passing through a particularly polluted environment, if you only spend a short amount of time there, your exposure levels is relatively low proportionate to the rest of the day. But you can see, importantly, variation between these different cities across Africa. The other thing I really want to pull out, and particularly from 2 more African studies, one on the left is 3 studies in Gambia, Kenya, and Mozambique. It's a precise diet study. This is a pregnant mother and child cohort study with personal monitoring. You can just see the black bag that lady's wearing. It's got a personal air quality sensor with GPS in it, carrying around. They were all monitored in both the dry and the wet season. So you can see there are seasonal differences in all 3 countries, strongest in the Gambia. But what I really want to pull out there is the distribution. It's the heterogeneity. Each one of those dots and within the box plot is a participant. So some of those women who were living very similar lives to the others in their cohort had very, very different exposure levels. When you look just at an average, whether that's an ambient average or indoors, then you are smoothing out the population's exposure levels. There are certain things that those particular women are doing, which means they are very highly exposed or have very low exposures. The same with the children on the right. Again, these 6 different cities, traveling to and from school and being at home. So even though these children are living in the same city, in similar kind of housing, similar socioeconomic status, a very large range individually in exposure levels. And that's important. We need to really understand what drives those very high exposures for some participants in the context of knowing that other participants have got very low exposures. So this is something we can solve. If you just look at the averages, people can counter it with, well, this is a very difficult problem. But when someone in your class or someone in your neighborhood has a very low exposure because of the way they are behaving, the way they're living, the way they're traveling, then you know that there is something you can do because your neighbor has got a much lower exposure than you. So that heterogeneity across the population is something that's really important to remember. How do we know this? So the GPS trackers for personal exposure monitors are extremely important. They can tell us where someone is when we measure a particular concentration. So remember, these sensors can take They take readings continuously, and they're averaged either to 10 seconds or more typically 1 minute. So we get a minute by minute breakdown of where someone is through GPS. Now, in the top panels there, you've got London. This was a study we did with professional drivers, taxi drivers, and van drivers. And we were able to break down their day into different sections, whether they were working, where they were driving, what the traffic levels were like, etc. And actually, across a larger cohort, we can break their day down into different categories, which is what's on the right. Were they in a cafe or a shop? Were they in a transport microenvironment or actually in a transport station? Were they in a supermarket? So we break down these different microenvironments that people interact with during their day to look at which are more polluted and which are less polluted. And then we can start to take action as to where they are and those particularly polluted environments. So in London, you can see that cafes or restaurants produce the highest exposure levels. So that's something we can focus on. The example from Kenya below, I think, is really interesting because typically we hear that in some of these more rural or peri-urban areas, the home is the most polluted environment if they're using biomass solid fuel methods for cooking. This particular participant, we can see from the GPS, around midday, they traveled away from home and into the market. And that is where they experience the highest levels. So you can see the cooking peaks in the morning and in the evening at home, but actually the highest peak in exposure was in the middle of the day when this particular woman was at the market with the various cooking stalls around there. So we can really start to look into what people are doing and where they are when they get the different exposure levels. This can be useful to try and model personal exposure. So we've talked about modeling ambient air pollution. Now we're looking at modeling personal exposure. So what is it about a cohort? Are there common patterns which we can pick out to say, on average, this particular behavior or environment leads to higher exposure levels? So this is a mixed effects model produced for those school children from the 6 cities across the African continent that I showed you earlier, where we're pulling out those variables which led to a significant increase or decrease in PM2.5 exposure levels. And we start to pick out different forms of commuting, different forms of cooking, different forms of lighting, whether it's kerosene or electric. Not surprisingly, whether there was a smoker in the house. These things are significant drivers of exposure levels. So from a relatively simple questionnaire, we're able to predict using this kind of model what the exposure of an individual participant will be. That's the theory. And in practice, it works in some situations and not in others. So in this particular study, with the school children, we were able to predict exposure levels reasonably well. In other studies with the pregnant women, it's much more challenging because people live very complicated lives in very complicated surroundings. So in theory, we can predict personal exposure. In practice, it's much more difficult. The other thing we can do with personal exposure assessment methods is link acute health responses to environment and therefore behaviors. So this is a study from a number of years ago now where patients with COPD, these were really quite poorly people. They had respiratory disease. They were used to going and seeing their GP into the hospital quite regularly. So they were willing to carry this pollution monitor you can see there with a GPS in it for 6 months. So for 6 months, every day when they got up, they put the pollution monitor on, carried it around. So we were able to link their pollution exposure to their respiratory health, lung function, symptoms, medication use, etc. And then what they were actually doing during the day to drive their exposure levels. to try and see if we can give them personalized advice on how they can change their behavior to manage their disease better. And there was some success here and able to give them advice on how they can travel, how they can behave in their home around ventilation and so on. But again, this field of science, that's the theory, but it's much more complicated. And we could not find a robust predictive model to predict when the symptoms of a COPD patient would worsen based on exposure. So our hopes of being able to produce a tool that COPD patients could use to improve their health weren't quite realized. It's more complicated. Yes, I've gone through that. So these personal techniques are really powerful. In theory, they're capable of measuring what we breathe, but clearly we can't give everyone a monitor. And more importantly, we can't give everyone a monitor to carry for the rest of their lives. 6 months was pretty exceptional and the longest study anywhere in the world that I'm aware of. Typically, people get bored of carrying one of these things after a week or two. Conversely, a model theoretically is capable of estimating what a population breathes based on questionnaires, assumptions, other data, etc. But how do you know if those are correct? So the conclusion that we're coming to is you need this combined monitoring and modeling approach to personal exposure assessment. And why would you want to do that? So let's go back to the same schematic again and look at it in a bit more detail. What can we actually influence in this schematic to try and make people's lives better? We can look at building design, and this is particularly important when considering things like thermal conditions. So as we insulate our homes better, or as we use different building materials, which make them more airtight, then that balance between indoor and outdoor sources will change. We can think about where we build our housing. Do we put it near busy roads or near industrial areas? What do we make them out of? We can think about how we travel around the city, different modes of transport, and how that relates to exposure levels. And we can think about the balance between active travel, cycling and walking, and more passive travel, and what this means to our exposure levels and health. But everyone's different. Everyone behaves in different ways. So we need some way of capturing how people behave in a city. And that is also going to change according to how old you are, whether you've got sensitivity to different pollutants. So you can see this balance between all of these different aspects of life and how we behave and our own particular sensitivity can make it very difficult to produce personal models. This is one attempt, the Apex model, but what I want to really highlight here is the different kind of models that have all been brought together to try this. There's the outdoor spatiotemporal model that I've shown you a few outputs from. There's a separate indoor air quality model looking at sources and behavior indoors. Then there's a building stock model. So in this particular space that you're modeling, what do the buildings look like? How big are they? How they are orientated? Then you've got this kind of behavioral activity model to try and capture how people interact with the city. All of these need evaluations, so you need a very, very large data set of personal exposure measurements to see if the outputs that your model is producing are realistic. And then you can start to do all sorts of different things around policy, around scenario testing for different behaviors, engaging with the public, etc. So in theory, a model like this can be very powerful. In reality, the Apex model is still in development, hasn't really realized all of those things for the complications that I've explained. I think it's important in research not to give too rosy a picture of the state of science. So finally, how can we reduce exposure to protect public health? First of all, let's review why exposure assessment is important. So the usual one that's highlighted is stronger epidemiological evidence. Like those very, very large studies in the US, Canada, and Europe, stronger epidemiological evidence can go through to produce stronger environmental legislation. Stronger toxicological evidence, if we can link the particular sources to the particular endpoints, we can look at which sources of pollution are more toxic than others, which will allow us to prioritize emissions control. Do we need to focus on vehicles? If so, is it diesel vehicles or petrol vehicles? Do we need to focus on biomass burning? And then more target evidence for health protection. So, how do we advise our populations to behave and protect themselves from air pollution and exposure? And this is really important and is becoming more important over time. The recognition that there is a social justice angle here. Generally speaking, the public do not really understand air pollution exposure. Therefore, they don't understand the agency they have, how they can help protect themselves from this health risk, this very significant health risk. So there is a social justice right to understanding air pollution exposure so that we can educate the population so they are able to make their own choices in combination with the governments and the other technical organizations who are trying to reduce the emissions themselves. And this can be really quite powerful methodology. Because you're putting air quality data into the hands of communities with sensors, whether they be low-cost fixed sensors or wearable sensors, they're much more engaged with it. And if they're more engaged with it, the data is within their own neighborhood context. So this availability of technology, which allows us to give communities sensors to monitor air pollution levels in their neighborhoods, allows them to gather their own evidence. And they will trust that evidence because they have created it themselves. They'll be able to argue and debate with their neighbors themselves rather than bringing some unknown scientist or unknown policy person in to argue it. So there's a greater level of trust, greater level of acceptance. The risk there is that the evidence is not sufficiently robust. So it's wise to have a level of oversight of those activities. But if done properly, this can be a really powerful instrument for change. And I love these two photographs. The one on the left is a residents association who got a fixed air quality monitor, and they actually knitted air pollution levels onto those panels that they got from their air quality monitor in their residential block, with the darker colors representing worse air quality. I think blue is nitrogen dioxide and pink is PM2.5, I think. So they've knitted the air, literally. The one on the right, these are got school bags with air quality sensors in there, just hanging on the peg rack, just like a normal school bag with their school books and their smelly trainers in. So that really is bringing science into the community in a way that makes it much more acceptable. So I'm going to finish off with a couple of quick quizzes. So at this point, I want you to wake up, pull up your chat box and give me some answers. There's just two questions I'm going to ask you, and I have to apologize. They're both based on London studies. I would love to do one of these studies in your cities as well, because I do enjoy doing them, and the results are really, really interesting. But for the time being, I'm going to have to present London. So put yourself in the shoes of someone who lives in London. We took 7 volunteers who lived in London and gave them black carbon monitors with GPS. So black carbon is a measure of combustion. It might be vehicle combustion, it might be wood smoke, anything like that. We met them all in the same part of London on the same morning, gave them a monitor each, and then they went off to have their 24 hours just as they would any other day. And we deliberately chose 7 people with very different lives. So there's a toddler, school pupil, office worker, home worker, cycle courier, ambulance driver, and a pensioner. In the chat, could you tell me which one of these had the highest exposure in your estimation? If we're in person, I'd be asking you why, but we're not. Lots of cycle couriers, pensioners, people who work near roads, ambulance driver, another ambulance driver, a couple of toddlers, school pupil. Well, we've had almost everyone except the office worker and the home worker. But other than that, we've had all of the others. Some of you are right. Right, stop there. Now, I want you instead to tell me which of those you think had the lowest exposure. Home worker, office worker. inside buildings. Home worker, toddler, that would be good. Pensioner. The ambulance driver. Okay, interestingly, we've had some that people think are the highest exposure and some people think are the lowest exposure. I think it's fair to say that the office worker and the home worker are winning the lowest. I'm impressed that the cycle courier has lots of highest, but a couple of lowest as well. So let me see what this is. Highest exposure was the ambulance driver, not the cycle courier. So the cycle courier and the ambulance driver had quite similar work days. The main difference between the two was the ambulance driver was inside a box, inside the vehicle, the ambulance itself, whereas the cycle courier, even though on the same roads, was continuously ventilating. So the exhaust that they both experienced was able to be ventilated very quickly with the cycle courier. And in the ambulance, it actually got trapped inside the ambulance itself. So when the vehicle pulled up behind another vehicle, the exhaust pipe of the vehicle in front went into the ambulance and got trapped there, whereas the cycle courier was able to be blown away. Now that's really worrying to think out of all of these, the ambulance is the most polluted environment with some very sensitive people in the back of that ambulance. The lowest was the office worker, and I think a few of you got this one right. And if we look at the office worker's trace, you can start to see why. So this is minute by minute pollution levels that they breathed throughout that 24-hour period. So they started about 7:30 in the morning at Guy's Hospital. They travelled to work. We can see to the nearest minute, I think that's probably about 9:11, 9:12. They went into their office in central London. Now, this office is in the most polluted part of the UK. So if you purely looked at an ambient air pollution map without considering behaviours or buildings, then you would conclude that the office worker had the highest exposure. But it was in a mechanically ventilated building which had very, very efficient pollution filters. So a very, very clean environment. We can see to the nearest minute when he went out for lunch and when he went back into the office at the end of his lunch and when he travelled home. Now, when he was at home in the evening, he lived in suburbia. He had the windows open, and actually, even though it was in suburbia, pollution levels were higher than they were in central London because it didn't have a filtration system. It was entirely naturally ventilated. So these kind of studies can really highlight some really interesting things. But one thing is very, very clear, the difference between being indoors and traveling. Another interesting one was the school pupil. So the school pupil, not through because we told him to, but he chose to walk to school and catch the bus back. And you can see by the different colours of the dots. So the dots are close together because he's moving slowly. He crosses some busy roads. He gets to school. The school environment's actually very clean. And then he catches the bus home. And the bus, just like the ambulance, trapped in queuing traffic, pollution levels many times higher. So the walk is not only good for him in terms of him taking exercise, but it's also leading to lower exposure levels. Go through that. Right, so that was the first one. Second one. Similar experiment, same instruments, but this time what we did, we took 6 volunteers. We asked them all to travel from A to B at the same time in central London. One of them was a cyclist, one of them walked, one took the bus, another drove along the same pollution route, the shortest distance between A and B. Then we took a cyclist and a pedestrian and asked them to walk and cycle a particular route that we had picked for them, which was very low exposure. So it avoided all of the congested roads. So still A to B, but along a low exposure route. Same as before. Who do you think had the highest exposure level? Bus, bike, car. Bus is definitely winning here. Car coming second. Right, I think we can conclude that most people think the bus. So I'm going to move on quickly to who had the lowest. Bike and walk. Yeah, bike and walk's winning. Now, the thing I like about this question is it tests whether you lot have been listening, because you should know from the first one that the bicycle, if you compare the bicycle courier to the ambulance driver, the courier had lower pollution exposure levels. So you should know from this test that the bicycle cyclist should have lower exposure than the car. But let's have a look. So the highest exposure was the car, not the bus. And if you think about it, they both had similar levels, but the bus is stopping and starting and opening its doors to let passengers in and out. The volume of the bus is much bigger than the car, therefore pollution levels do get trapped inside the bus, more so than the cyclist and the pedestrian, but less so than the car. And the bike had the lowest exposure because of that ventilation. So if we have a look at the cumulative exposure, we can see that the car is many times higher exposure levels than even the bus, and certainly than the cyclist and the pedestrian. You can see the different times it takes, and actually the cyclist got to the destination much, much quicker than the car and the bus anyway. So in terms of public information, you can encourage people to take active transport. That's better for their health because they're exercising. They will get there quicker. It's cheaper, and their exposure levels to air pollution will be much, much lower than the car, which is the biggest surprise. I think people often assume that the cyclist will have higher exposure levels. Now, there's one caveat to that. Vehicle manufacturers have recognized this, and high-end vehicles now putting effective pollution filters on their ventilation systems. So if you can afford it, you can protect yourself by buying an expensive car which has got an air pollution filter on it, which means that your exposure levels won't be higher than the cyclist. They may even be lower. So that's another example where equity issues are important, that those who can afford it can protect themselves and those who can't. Having said that, that's still a relatively low proportion of the fleet, and many vehicles around the world, these results are still going to be true. So just to finish off, where are we going next? Some parts of the world have had really quite highly resolved ambient air pollution models for several years, but now with the improvement in satellite products, with the improvement of the processing of those satellite products, the resolution of global models is improving all the time. And actually, you can see this really clearly in the Global Burden of Disease study, where the ambient air pollution exposure estimates are improving every time the GBD is repeated, which is partly why the ranking of ambient air pollution does change. I've tried to present as much evidence as possible from the global south, from my own studies, but there are still big evidence gaps in the global south, particularly now on the African continent. And this is a combination of measurement resources, that scarcity of reference monitors, and even scarcity of low and mid-cost sensors, but also entirely different situations. So some of the evidence from the global north can be translated from south, but as I hope I've shown you, these behaviors are important, the environment is important, and you can't assume that evidence can be translated. That's changing. There's increasing evidence now coming relevant to different parts of the world. At the moment, there's a number of indoor air quality models and outdoor air quality models. There is now a move towards combining these to produce something which is much closer to a personal air quality model. Not personal because it just considers the indoor and outdoor environment, but these are really important, particularly as you're thinking about future building design, thinking about energy efficiency, thinking about how you protect your populations from increasing heat and climatic variability. So we really need to consider indoor air quality, both in terms of ventilation of indoor sources and in terms of infiltration of outdoor sources, as we look to improve the design of our buildings to protect health in other ways. Then the next step on from that is dynamic exposure models. And these are the ones that consider how a population moves around a space, include behaviors around transport, behaviors around how people move to go to work or to school, how much often they open windows, how often they cook. So that's the next level of complexity up, and these are beginning to come along. Very, very difficult to validate because every person in that model behaves differently. So really difficult to validate, but they are being developed. This evolution allows us to really focus on those who are most at risk of harm from air pollution and integration of population behaviors which are typical of particularly vulnerable people. So this may be elderly people, it may be people with existing health conditions such as COPD or cardiovascular health, it may be young children, school children, it may be pregnant women, etc. Each parts of those population behave differently or in different environments. So we need to integrate different data sets to accurately capture them. And then start applying all of these exposure assessment tools to epidemiological studies and understand why a study which only considers ambient air pollution may have different results to a dynamic model or a combined indoor-outdoor model, and what this means for policy development. This is still in its infancy and not particularly well developed yet. All of that is kind of research orientated, but actually, hopefully, you can see that these exposure assessment tools are also tremendously useful for engaging with the public and policymakers to help them understand air pollution. It's often presented as an invisible threat. So these kind of methods, which are more engaging, more personal, help people we're trying to engage with understand the issue and engage with the issue to try and drive change. And that's tremendously important. Now, this final point on I'm really, really think is extremely important. And that's the integration of other environmental exposure metrics. This is most true or being most demonstrated in the increasing number of studies which are considering the combined effects of heat and air pollution. But it can also be true of noise or light or nutrition or pre-existing conditions. So considering air pollution in isolation of these other public health risks, particularly environmental health risks, risks biasing the subsequent actions. We need to drive change that protects public health in a more systematic way to avoid unintended consequences or to avoid actually making the situation worse unintentionally by improving another situation. So I'm a great advocate for studies which consider a number of environmental exposures and not just one in isolation. So there's a stack of reading for you there, which you're welcome to engage in. And I'm assuming that these slides will be provided to you afterwards. But hopefully that's given you quite a lot of things to think about. You're a very, very diverse group. Thanks for introducing yourselves at the beginning there. I can see there's people from all around the world in different situations. So hopefully we've got a little time to have a discussion and answer some questions.
Yes, indeed. I think we do. Thanks, Ben, for addressing what I call in many rooms that I've been the elephant in the room. Often we talk about air pollution being an issue, but attributing that exposure to the health impacts for different populations, different sort of, and I think you've brought the point home in terms of just looking at ecological exposure for large groups versus how people behave, and in the questions that you posed to the group there at the end, in fact, which have generated some discussion in the chat, which I think is where we should begin. For the car, actually, some people. So I think Africa is primarily. You did say that manufacturers are increasingly including high-end filtration devices, but these cars are expensive. Most of Africa is primarily a used vehicle market, with exceptions maybe South Africa and a couple of others. So I've seen a couple of questions here. Someone asking, does it depend on the type of car, the type of fuel, year of manufacture? Do those play a role? So maybe we can start there. And as folks also keep posting their questions in the Q&A, which we will go through next. So Ben, how do you think you can address that?
So we did a study to try and answer that question, looking at taxi drivers. So half of our cohort were traditional diesel taxi drivers, the other half were EV taxi drivers, looking at exposure levels. And what we found was the EV taxi drivers had significantly lower pollution levels not because they were driving an EV car. It's because that vehicle had been designed to a higher specification and was more airtight and had better filters. Because it's not the vehicle that you're driving which self pollutes, it's the vehicle in front which is important, the vehicle around you, all of the vehicle around you. So um, it just so happens that the EV vehicles had better capability of keeping that pollution out at the same time as not producing their own pollution as well. So it does depend on the vehicle, its age, its manufacture. We did test some vehicles which were very high end and claimed to be very protective and actually leaked like a sieve. So you can't assume that the expensive ones are the best. I think generally speaking, things are improving. There's some really interesting research gone on in school buses as well in the US, looking at different pollution levels within school buses.
Yeah, thanks for that. So I think, yeah, it really depends. But essentially the pollution is coming from the vehicles around you. So I'll go straight to the Q&A questions. And I think the first one, which is very interesting from Habtum, he says, thank you for the presentation, Ben. And a majority of LMIC's populations reside in rural areas where biomass burning is the predominant fuel source. So this sort of setting, demands a unique intervention strategy. So if he says it appears multifaceted approaches, combining public awareness, clean cooking, kitchen structure modifications are necessary. So his question is, from your perspective, what would be the most practical intervention strategies in such settings in LMICs?
Yes. So on a very, very basic level, replacing solid fuel with a cleaner fuel, um, gas or preferably electricity. And I say a very basic level because your audience will know much better than me. There's more to it than that. Um, Around things like taste, accessibility, cost, cooking methodology, etc., etc. So I think there is no one answer to that. I think it will depend on the local setting, depend on the local community, what the community itself wants, and what is accessible to that particular community. And every community will have a slightly different um, approach. There has to be option and there has to be availability of options to drive that change. One thing I think is an important finding from one of our studies that's not yet published is similar to the vehicles, actually. If you change the fuel of a particular household, you will improve the air quality within that household, but not as much as you would think if all of your neighbors are still using biomass cooking, because that pollution comes out of their home or air cooking area and pollutes your own. So initiatives that intervene on a larger scale than just individual households and try to affect the whole community are going to be much, much more effective.
Yes, I think the key thing there is scaling it in a way that exposure is minimized for the entire population as opposed to single households. And I think many governments are trying to incentivize different forms of clean energy, but they're becoming expensive as well. So something to look
Yeah.
forward to for the continent. Another question here from an anonymous attendee. You can drop in your name with the questions, listeners, participants. He says he or she says one question they get all the time is personal monitors are not sufficiently reliable or validated. That's interesting. What is the best commercially available air quality monitor for research applications? So I don't know if you want to answer that or yeah.
Fortunately, I don't own my own company, so I can't push my own stuff. So I'm going to hedge around that one a little bit. So first of all, it depends on the pollutant. I would absolutely agree. I am yet to be convinced that any personal monitor can monitor anything other than PM2.5. Very difficult to monitor nitrogen dioxide, volatile organics are very difficult. PM1, PM10, very, very difficult. So let's just focus on PM2.5 and probably carbon dioxide. So then you need to think about what is the purpose of your monitoring. Often, particularly in those two experiments I showed you, what's important is the comparative concentrations. It doesn't necessarily matter whether it's 22 or 25. What matters is it's more or less than the other person in the comparative experiment. So you need to design your experiments to the accuracy of the sensor you're using. The precision therefore becomes important. So that experiment where we gave all of the different participants the same type of monitor at the same time, before we did that, we calibrated them all side by side so we can be absolutely confident they all read the same thing. We didn't mind so much about the accuracy, but the precision was really, really important. There are other things you can do, calibrating before or after, etc., but it's a difficult job being personal monitor and dealing with those changes in temperature, etc. So I think my sort of slightly elusive answer to that is think about your experimental design and play to the strengths of the personal monitor and not its weaknesses. If you want to compare it to regulatory standards, you're going to struggle. If you want to compare it to another member of your cohort, it will be perfectly accurate enough to do that.
Yeah, thanks. And I'll just add for the participants also. In our first session, we actually went into some detail on measurements in terms of um, sensors versus reference monitors, gases versus particulates. So you can access the recording in the link that we've provided. Essentially, as Ben says, yes, it's a difficult one. It depends on what you want to achieve. Is it regulatory? Is it exploratory? And you need to make considerations for certain gases versus particulates also along the way while conducting your research. So I would encourage you to also have a look at that recording, and the slides are also available for that. And that's essentially why we are trying as much as possible for this series to cover all the bases so that as we continue this discussion, we have sort of covered the basics for measurements, exposure assessment, and future sessions looking at epidemiology. So next question, again, for the ambulance example that you gave, Subu is asking if the ambulance has, since it was the highest exposure, I think it was, if they have an air filter in the intake, or does the driver keep the windows open, if at all?
Uh, if you're confident that your vehicle has got an effective air filter, then driving with your windows closed but the air filter on is the best approach. What you want to try and avoid is driving for long periods of time with recirculation on. So if you're just recirculating the air, it will keep the pollution out, but it will also allow carbon dioxide levels to build up, which can cause drowsiness. So then you've got a safety concern. So my general advice in high income countries is if you're driving through a tunnel or if you're behind a particularly dirty vehicle, temporarily switch your ventilation to recirculate and then switch it back to incoming when you've come out of that situation. And that honestly is how I drive. When I drive a vehicle, I do that myself. So I'm practicing what I preach. It does. I noticed there was a comment there about self-pollution, and yeah, a poorly maintained vehicle is actually capable of killing the occupants through carbon monoxide poisoning. So yeah, you can self-pollute if you've got a particularly poorly maintained vehicle, and in those situations, then I really don't think an air filter is going to make the slightest bit of difference.
Yeah, I'll make a point of trying to drive like you do. Thanks for the pointer.
Even
So
better,
yeah.
don't drive. But
Oh yeah, I can alternatively cycle. So actually going to that part of the discussion, you did mention that exposure is a function of time. So we have a question from Paul about the cyclists. He's asking if you considered breathing rates and the duration for which they were cycling as well.
yeah, really, really knotty problems. I've had several arguments with a colleague about duration. So if you look at cumulative exposure of the cyclist on that particular experiment, if the cyclist gets there in 15 minutes, their cumulative exposure is really quite low because it's only over 15 minutes. Whereas the car driver, it goes much higher and it's over a longer period of time. That cyclist was doing something for the remainder of the time after they'd reached their destination. They didn't suddenly stop breathing. So you have to be careful with cumulative exposures that you don't just drop to zero. And I honestly don't have a good answer to that, but most members of the public don't ask that question when you present. When it comes to dose, So there has been a fair amount of research and publications on looking at dose. Uh, Volume intake is not tremendously easy to estimate. Everyone has different volume intake and breathing rates, but it's also not impossible. And actually, I don't find the evidence convincing. I'm not convinced that dose is a better metric than exposure. I think it introduces complications and doesn't bring a great deal of benefit. So I understand the logic there, and would expect it to have an impact, but as yet I haven't seen convincing evidence that we should be routinely considering dose and not exposure. Or what I will add is evidence from the Oxford Street 2 study. So Oxford Street 1 and 2 are quite famous studies carried out in London where asthmatic, COPD, and heart patients were walked around a polluted environment, which diesel-rich environment, which is Oxford Street, and then a couple of weeks later around a park, around Hyde Park, and very detailed physiological and biomarker measurements were made to see how their body reacted to those two environments. In the second one that I was involved with, what we found was the participants who walked along Oxford Street, their health did not worsen, surprisingly. But then when you compared it to the participants who walked around the park, their health improved. So actually, what the air pollution was doing was cancelling out the beneficial effects of exercise. So that exercise is absolutely key. And what that actually says to you, if you think about it carefully, is if someone says, I don't exercise in X city because it's too polluted, actually you're missing out on the significant benefits of taking exercise. So you should take exercise, but when you exercise, you should seek out areas that are less polluted to exercise. Don't go for a run along the side of a busy road if you can help it. Go for a run in a quieter area or a park by a river, etc.
Yeah, and I think that also speaks to the case for having data publicly available as well for various cities and city authorities and governments.
Yeah.
So just switching gears a little bit and acknowledging that we have a very diverse set of participants. We have a question from Abdul Karim, who says some meteorological events drive air pollution exposure. What is the best way to rule them out when you're doing pollutant exposure measurement?
Yes, we certainly found that in Gambia. Um, uh, so this is where toxicity is really important, and I have not worked in the Middle East yet, but I'm hoping to go out there in October to start a study, the same study that we conducted in London. We're hoping to do in the Middle East, because the desert dust is incredibly dominant during certain periods out there. So my advice would, first of all, don't leave it in there. Look at health associations, look at exposures, so it allows you to compare actual exposure levels, and then do take it out. So I would suggest, some of our experiments, including those carried out in Gambia and Mozambique, Gambia in particular, the study design was we gave personal sensors to the participant, but we also had a small network of fixed sensors. And they were the ones that we used to identify regional sources of air pollution, like Harmattan. Because they were continuously in the same place, and we could look at windroses and understand where the pollution was coming from, independent of indoor sources of behaviors, etc. So in terms of study design, placing a fixed site sensor which can continuously monitor away from any local sources to assess those meteorologically driven regional sources. And then if you wish to, you can subtract those concentrations from the personal exposures.
Yeah, that sounds like a good strategy. So I'm seeing some questions also in the chat. So maybe I'll switch over to that, which is a very practical one. Linking air pollution and health effects is difficult in most developing countries, like Nigeria, I think Ezekiel says. How do we accurately achieve these assessments in order to help policymakers to encourage both monitoring and consciousness? I think he means public awareness.
Yeah. So again, there's no one answer. I've mostly worked with cohorts. So cohort studies are powerful because you're in charge of gathering the health data and you can verify its completeness and its quality and what particular metrics. But they're expensive and time consuming and not very widespread. So ultimately, you do need a robust set of administrative health data, hospital records, GP records, etc. And I know that this is something which is improving in a number of countries, and pressure that encourage governments to invest in robust health data systems will have very, very wide-ranging benefits, not just in epidemiological studies for linkage, but also in health management in general. So I think that's one where advocating for robust, preferably digital if possible, health data systems.
Yeah, I think we are still struggling on most of the continent to digitize, although health information management systems are slowly becoming a norm in most of African countries. But yes, we do have, depending on the level of hospital you're talking about, is we do have some way to go. So that's noted. David is asking a specific one here. Thank you for the presentation, Ben. A popular problem in African countries such as Kenya is waste management practices, including open burning, I think, is what he's trying to say, which affects air quality. Are there anything we can borrow from the UK, for example, in waste management?
Yeah, it's a difficult one. The most extreme case of that I know of is in Indonesia, where they're actually using plastic as a stock feed fuel to make food. So they're using plastic as a fuel source rather than a waste burning, which is absolutely terrifying. Um, what can you learn? I'm I'm not sure that we got everything right in the UK, certainly, and many other countries. I think we did a number of things wrong. So one of the things that developing waste management systems should learn is not how not to do things. Don't make the same mistakes that other countries have made um, around stockpiling, burning management, etc. The small scale waste burning is a difficult one. I don't have any good answers for that. All I will say is we were not able to identify a distinct waste burning source in any of our studies. We thought we would be able to. We thought because some of our participants, particularly the school kids, made notes if they walked past it, we thought we'd see spikes. We didn't. So what we weren't able to do was generate evidence to present to policymakers to say, look, this is what a kid is breathing. This is where they walk past someone burning rubbish. That was a hope at the outset of the study, but we weren't able to do that. I think that's one of those situations where purely in terms of PM 2.5 or black carbon, the concentrations are not as high, but purely in terms of toxicity, burning waste is highly toxic. So it's possible that our sensors weren't sensitive enough to the highly toxic components.
Yeah, exactly. So we do refer to dioxins and furans as well, as many other toxic chemicals, just class one carcinogens, as being in the mix for open burning type, depending on, of course, what you're burning, plastics, all these kinds of things. So it becomes a bit more complex, but it's a practice that needs to be highly regulated, I believe. So we still have 5 minutes or so, so I'll take a last round of questions. And I'll put two together, which allude to the whole discussion about duration and the WHO guidelines, 24-hour and annual, etc. So one of the attendees or participants didn't leave their name, says, thank you for sharing. Do you think it's useful for individuals to see their daily exposure, especially comparing them to WHO guidelines? Do you think it can give them some guidance on what actions they can take for the rest of the day, essentially try and influence behavior?
So you'll have noticed that I didn't include WHO guidelines on any of my graphs today. And there's a couple of reasons for that. One is because most of what I presented was much higher time resolution than 24-hour. And I don't believe in putting a line with a 24-hour standard, health standard, against a 1-minute data point. You'll see lots of people doing that. I don't think it's appropriate statistically. Whether it is useful. So daily means can be useful, particularly when you're looking at relatively large scale pollution. So if the pollution across the whole of a region, part of a city, town, village is exceeding over 24 hours, that is a useful, very useful indicator, particularly to put pressure on authorities that they need to take action. The challenge there is what agency does the individual have to change their own exposure for that large scale pollution. Conversely, it may so be that exposures inside a home are over the 24-hour mean, which means that the home is really quite polluted most of the time. And this does happen. In which case, it's their home. There is some agency. It may so be that they cook differently or they ventilate differently. The kind of behavioral change around transport modes, shorter term behaviors, probably not applicable to show 24-hour means. The health impact side of that is still somewhat tricky. So we don't have robust evidence of the health impact of very short, sharp exposure peaks. So what drives the health impacts that we do see over a 24-hour period? Is that a very high consistent level, or is it a series of short spikes, both of which average out to the same concentration, or is it a combination of the two? We don't know. We don't have the evidence to know what the health impact of 1, 5, 10-minute very high exposures is in comparison with 24 hours. So I would love to find out, and I'd love to do studies that have been able to do that, but as yet, our data has not been robust enough to do that.
Yeah, I think which is why Thomas in the chat is asking, just going back to the same point, at what hourly or maybe 24-hour period do the concentration levels would you expect to see adverse health effects from black carbon exposure in sensitive populations such as asthmatics or elderly? I guess we go back to the same, yeah.
It is a similar thing, but there's the added complication that black carbon is not widespread monitored. It's not monitored widespread, in part because black carbon levels in developed countries now are very, very low. So monitoring has dropped off. I am not aware of any dose response relationships for black carbon, which is why there are no WHO guidelines, but I'm very happy to be corrected.
Yeah, I believe that's the case. We can look at black carbon as a component of PM 2.5. But yes, I mean, there are no specific dose response functions for for black carbon rather. So we are almost at time, but I'll take one more. How can we use, so Jaber is asking how we can use satellite NO2 data for exposure assessments because satellites provide column measurements. Yeah.
Yeah, so interesting. There's new products going up. There's a new product that's gone up. And I'm not doing this intentionally. I keep bringing up the HEI because it's directly relevant, not because you organize the sessions. But as it happens, there is application request for applications that's just gone in and being assessed next month. And one of the aims of that is to help develop algorithms to translate columnar NO2 into surface level NO2. So because it's a new product, the algorithms are not well developed yet, but that RFA will help develop those, and I would expect that they'll become open source. So I think surface level NO2 concentrations is something which will probably evolve very rapidly in the next couple of years as these new products become available.
Thanks for that. Yeah, I think many people are asking about the slides and recordings for the first session. We have shared a link to that. Please do access them there. And I'll take a final one because we have maybe 2 or 3 minutes from an anonymous attendee. How would the exposure be like in the tube relative to walking or driving? I think this is
Ah,
specific to London.
yeah, if you use the word tube, it is specifically to London. So one of my poor PhD students, James, spent a year of his life monitoring every single tube station on the London network twice. So he sat there for hours and hours and hours doing very, very extensive pollution measurements. And he did it with PM2.5, particle number, and black carbon. There isn't really any black carbon. What he was monitoring with that sensor was black iron. It's not
Ah,
combustion; it's the wear of the rails. So what we found was in tube stations which are above ground, and actually quite a large proportion of the network is above ground. It's a very, very clean environment. It's not surrounded by other vehicles. You're in a nice little transport corridor. Because the doors keep opening and closing, the ventilation vents very quickly. So, and the DLR is the same. So, about any tube station anywhere in the world that's above ground is going to have much better air quality than the ones that come below ground. Depth of the tube station was important, but what was the deciding factor was how far away from um, a tunnel entrance you are. So if you're a long way from a tunnel entrance, pollution levels will be really bad. Two important things. One is it's not all coarse particulate. People believe it's coarse. It's not. There's a lot of PM2.5 down there, and the concentrations were probably 10 times higher than they were above ground. So very high, but very, very different nature of particle. A lot of iron, a lot of all sorts of other metals as well.
thanks, Ben. And I think you can stop it at there for the Q&A. Thank you, everyone, for posting your questions. We really appreciate your engagement through this session. And thank you, Ben, for really highlighting a lot of the challenges and we face in the course of, trying to do exposure assessments for health studies. And thank you for your time. And I think this is a very interesting session and the engagement with the participants as well. So I will just say before we finalize, we do have a link, a SurveyMonkey link that has been, I believe, posted in the chat. We invite you to give us, as we close, we invite you to give us your comments or how you find the sessions as we go along. I think we're really trying to make for those of you who love soup, a kind of soup in the course of this series. So we've had the first two ingredients. The last session and today's session, we still have two more sessions to go. And as you know, it's the soup is the final product, but the ingredients make it tasty or otherwise. So thank you, Ben, for being a part of our soup making journey. We hope to see you in future as well. So I will just want to go back and make a couple of announcements before we close. So for our participants, which I think are quite relevant. So we do have the first announcement, the Future Future Leaders Fellowship program that we are launched in collaboration with the African Clean Air Network. Just 10 more days to go. This is open for PhD and master students, graduate students, essentially across the continent. So we look forward to receiving your applications. Everything is available for you. Next week, we are also organizing in the run-up to the Clean Air Forum that I mentioned earlier, a webinar, a health case for clean air investments in Africa. We'll talk a lot about some of the things we've discussed today, the health impacts of air pollution in Africa. We have a wide variety of speakers available for us on this day. So we invite you to to register for this webinar. It will be Actually, the next day after our next session on epidemiology introduction to AP. So look forward to seeing you there at this session on June 17th at 5 p.m. Eastern. So the link also is available for you to register. I believe it will be posted in the chat. So as we close, without further ado, I'd just like to acknowledge and recognize my colleague Pallavi, who is in the background posting the links and everything. Thank you, Pallavi, for your time. Also, thank you to my colleagues from the comms team at HEI for organizing the webinar and sending the reminders and communication material to the participants who have registered. So look forward to seeing you at the next one, and we will leave this open for a few more minutes so you can take the link for the survey and fill it out. Otherwise, we have had a big group of participants, maybe 30 or so different countries from across the region and beyond the US, India, and other continents. Thank you so much for being with us this evening, this morning, this afternoon, depending on where you are. We look forward to seeing you at the next one. And as always, the slides and the recording for this session will be available on our website on the event page. So thank you, and I will leave it at that. Look forward to seeing you in 2 weeks' time.